My name is Jay Detterman, and tonight I'll be presenting on medial patella plica syndrome. Tonight I'll be going over the definition, the anatomy, etiology, presentation, diagnosis, treatment, and return to play criteria. So to describe exactly what a plica is, it is an inward fold of the synovial membrane within the knee capsule joint. So there's a theory that's widely accepted that is formed during the 7th to 12th week of fetal development. And what happens is the knee develops in 3 parts, so the medial, the lateral, and the suprapatellar. So then these different synovial linings fuse together to form all of the joints in your knee, the ACL, MCL, PCL, LCL. So sometimes these don't develop quite properly, and sometimes they don't develop together at all, and that's how you get a plica. It's now considered a normal anatomical structure by some different sources that I found. There are 4 different types, as you can see just over here. You have the suprapatellar, the medial parapatellar, infrapatellar, and the lateral parapatellar. To describe exactly what a medial patellar plica is, I'll first describe the function of it actually. The function of it, it's actually believed to kind of act like an eyelid for the knee, so to kind of provide some lubrication to the femoral joint as well. So to describe the MPP syndrome, I'll quote here from Zanajgerman et al., who quoted painful impairment of knee function in which the only finding to explain the presence of symptoms is a thickened hypertrophic plica. To go through some of the knee anatomy here. So the knee is a hinge joint which allows for flexion, extension, and some internal and external rotation of the lower leg. It's comprised mainly of the tibiofemoral joint, the tibia, femur, fibula, and patella. It's held together by your ACL, LCL, PCL, MCL, as well as the meniscus for shock absorption and some proper joint health. The plica is prevalent within about 50 to 95% of the population, and that's just an overall population, that's not just an athletic population. And the incidence of this syndrome is only 3.8 to 5.5% of people, so it's not a very common condition, so that's why it's very undiagnosed and misdiagnosed. There are 4 different types. So you have type A, which is more of a cord-like type structure. Type B, so you have the shelf-like structure that doesn't cover the femoral condyle, and also type C. As you can see here in the picture, it's more like type C, how it kind of covers the medial femoral condyle there, and then also type D, which has 2 insertion points. As far as the etiology goes, like I said, there's only 3.8, 5.5% of people that have this, so just because you have a plica doesn't mean that it's necessarily pathological. It's common in all populations of all ages. I've seen anywhere from age 7 to age 85, mid-80s, and even in cadavers there, sorry. The pathophysiology of the condition, it's mainly caused by 3 different things: blunt trauma, repetitive knee movement, such as flexion and extension, and then condyle damage, specifically like osteoarthritis, arthritis, things like that. It's also commonly caused by synovitis. To go through how this condition generally presents, the history, they'll generally present with non-traumatic knee trauma, roughly 50% of the time. Their chief complaint is normally that intermittent, dull, achy pain in the joint line. They'll have some increased irritation with flexion and extension of the knee 50% of the time, and then some popping, clicking, or snapping 25 to 37% of the time. With your observation, you might see some slight joint effusion, but you won't see much. Like I said, this varies quite a bit in 15 to 65% of the cases, so it might be there and it might be not. As far as palpation goes, you're really just rolling your fingers over the medial knee, right over the femoral condyle, and you might feel a little thickened band kind of snap or pop over your fingers. It is palpable in 84% of the population that has it. Special tests, so you're going to go through your manual muscle tests. you might see some weakened quads, and then with your special tests, you might see some tight hamstrings as well. There were a few tests that I found within the literature. The active extension and flexion test, which is exactly just how it sounds. You just have them actively flex and extend their knee. The sensitivity and specificity of that were not reported, unfortunately. Also, the patella apprehension test, where we just push the knee, the patella laterally, trying to check for any subluxation, dislocations, things like that. That also was not reported for the sensitivity and specificity as well. One great test that I did find within my research was the medial patella plica test. And this is a test in which you have the patient sit on the chair or on the table or whatever. You palpate the medial joint line, and then you passively flex their knee up to 90 degrees, or extend their knee up to 90 degrees. If they have any absence of pain with that, or any pain with flexion, and then a popping or snapping under your thumb, then that is considered positive. Within your evaluation, you should go through your differential diagnosis, so you should check for the MCL sprain, maltracting patella, Pezan strain bursitis, medial meniscus tear, arthritis, things like that. The gold standard for this is considered to be an arthroscopy, so this is just general scope. It's the only true way that we know to go in and actually see this condition. Again, the specificity and sensitivity of that, I mean, obviously you're going to see it or you're not going to see it. Imaging techniques such as the MRI, so this is your layered image of the knee. So the sensitivity of that was 7.77 and specificity was 0.58, as well as diagnostic ultrasound, which just gives you a generalized picture of the condition, or of the area. So that had a sensitivity of 0.77 and a specificity of 0.83. So to go throughout the treatment, the main goal is really to reduce inflammation and plica thickening, and that can be accomplished through rehab, modalities, surgery, and possibly pharmacological interventions. So rehab, this is really your first treatment. It's just basically a general strengthening of the quads, doing closed chain exercises as well as hamstring stretching. The hamstring stretching, it was recommended to do multiple times throughout the day as much as possible. And this is generally a 6 to 8 week program. For modalities, I really didn't find much within my research for modalities to treat this, such as ultrasound or electrical stimulation or anything like that. The only thing I really found were compression wraps or compression sleeve in combination with ice. So a common treatment may be like a game-ready type situations. As far as pharmacological interventions, NSAIDs are generally used within the rehab, within that first portion, trying to eliminate any swelling or reduction of pain. And then your second line treatment, this is generally after your 6 to 8 week program for rehab. That's the corticosteroid injection with cortisone. And that had a success rate of about 73%. Your last resort is the knee scope. And this is where they'll actually go in and remove the plica. This is obviously our last resort. We don't want to jump to this right away, as some research has stated, but just for obvious reasons, we don't want to put somebody through surgery when we can treat them in other ways. This was generally followed with a 12-week post-op rehab program, which I figured was kind of long, so I would recommend maybe the 6 to 12 week or 6 to 8 week program instead of that. Return to play. The current recommendations are fairly absent within the literature. The only thing that I could find were the 6 to 8 week programs for rehab, as tolerated with participation, probably to rest and ice and let that tissue like reduce in inflammation and things like that, in combination with your rehab. So today I covered the definition, the anatomy, the etiology, the presentation, diagnosis, treatment, and return to play for MPP syndrome. Are there any questions or comments?